Actually, we already started discussing about the appropriate transfusion practices in certain situations like obstetrics, ICU, massive transfusion. And in this second part, I will continue with the pediatric transfusions, which I think is by itself is a whole important area to cover, but it is also related to all other specialties. And also we'll talk about little bit about transfusion and sickle cell disease. The objective is to discuss some considerations in pediatric transfusions, the indications of red blood cell, platelets, and plasma transfusions in pediatrics specifically. We'll talk about thrombocytopenia and transfusion medicine. I think this will be very handy today, very important, since we have a case of thrombocytopenia here in IBRA, which created some kind of confusion, I must say. And then a little bit on aluminization and sickle cell disease. Okay, this is a very important concept before starting talking about pediatrics. Remember that pediatrics or children are not little adults. What it means in the past, even like this like 1800 or 1600, I think 1600, like in the 17th century, when famous painters used to paint children, they paint the dimensions of an adult man and they just make it small. But with time they discovered that there is a big mistake with this drawing. Children should not be painted like this. And do you know what's the difference? Then the recent paintings actually reflected an actual child. So if you look closely, the head of a child is not actually small. Children are different from adults. They have bigger heads because that's where their brain developing is. They have shorter limbs. Look at this child arms compared to this child. And children have bigger heads, shorter limbs, and longer trunks. That's how child is created. That's how he is developing. And this concept applies to everything else. You cannot just copy paste what's done in adult medicine and try to apply it for children. It does not work. And why it's different? Because the blood volume, for example, in children are much different from adults. A full-term baby has a blood volume of approximately 85 ml per kg. So if he's born like with 3 kg, that will be around what? 250 ml? 250 ml for the whole child. That's all his blood for a full-term baby. If he is a preterm, then he will be like 1.5 kg. So we'll have like 150 ml. Imagine 150 ml. That's the whole blood volume of that small baby. So that's where you need to think twice before taking more blood from him. Hematological values are different. Normal values for pediatrics are different from normal values for adults. We'll talk about this. The immune system maturity is very low. There is no immune system active in this child. And that has implications in terms of infections, transmissions, even in serious transfusion reactions that I will touch a little bit on. And physiological response to hypovolemia and hypoxia is also very quick. They can get affected by hypovolemia and hypoxia quickly. Usually we divide the children age in terms of transfusion. The first phase is birth to 4 months, and then anything above 4 months. That is slightly a different age groups for pediatrics. We say that the normal values in pediatrics are different, and this is a simple diagram. Neonates are born with hemoglobin around 14, and that hemoglobin level will drop sharply in the first day of life, and the first month, sorry. And then by the second few months, second or third months, the normal or the usual hemoglobin is between 9 and 10. And that will remain the same for up to 5 years. Okay? So many children, they come to the hospital for some kind of throat infections, viral, they do CBC, and then he will be treated for anemia. He is referred because he has a hemoglobin of 10. And I have seen many blood films ordered for pediatrics, iron deficiency anemia, iron deficiency anemia. That's their usual average hemoglobin, children. Why? Because they are using lots of their iron in the developing state, in creating their own body. Then for adults, this will be between, the normal will be between 13 to 14 or higher, and for women it will stay little bit below. So normal values for hemoglobin change rapidly, and it stays low in the first few years of life. So as with anything else in life, you have always to find a balance between the risk and the benefit if you want to transfuse a pediatric patient. And that's what they say, the elephant in the room. But you really have to choose wisely before transfusing a pediatric patient. You have to learn about the evidence-based. Is your blood request really indicated? Are there studies support your decision to transfuse this patient? And we talked about alternatives. Always look for alternatives. If this is true for adults, it is even more important for pediatrics. What could have a minor effect for adults, it can affect your child significantly. And remember, harm, if it happens in childhood, it can stay for a longer time. Unpredictable acute transfusion reactions. Nobody can predict some of the allergic reactions. Whatever you do all your screening, but suddenly 1 out of 100 patients transfused can have a serious reaction, and that we'll discuss further later on. Incorrect blood component due to errors such as mistaken patient identity is the major cause for mortality and morbidity in relation to blood transfusion. You have to be careful to identify your patient. The blood is requested for patient X and should not be given for patient Y because you just didn't ask his name, or they shifted bits during change of nursing shifts, and then you don't ask, just this blood is for that bit, without looking at the armband, without asking the name, and without confirming the blood is meant for which patient. It may sound very easy, but this is the first cause of mortality because of incompatible ABO blood transfusion. It is serious. So patient identification is very important, and this is all part of appropriate blood request. You have to have properly labeled samples, proper request with clear indications and clear diagnosis. The identification should include the first and the last name. Well, in the West they go by the last name first anyway. Date of birth and the hospital or national number. Some they use the MRN number as the hospital number. A patient identification band must be worn by all patients receiving a blood transfusion. You always have to check the armband and double check it with your blood unit. هذا وين خلنا نتصل؟ ما عليه تحت. As I said, some common side effects can happen, some more serious side effects that can happen also. You will have more discussion about this, and some rare but also fatal side effects, and nobody can prevent these adverse events from happening. So the best strategy is you don't give blood if it is not necessary. The only way to prevent most of these reactions is to avoid blood transfusion in the first place. So the physiological anemia of infancy that we discussed, the first few months there will be decrease in the hemoglobin and the red blood cells after birth, and this is because the child will come out of the uterus and suddenly will be exposed to an oxygen-rich environment. And you remember that erythropoietin produced by the kidney in response to hypoxic state, that will have an opposite effect, and because of oxygen-rich environment, the production of EBO will be reduced. EBO levels will be decreased, and then hemoglobin at 2 months can go up to 90, usually 90 and above, but it can go lower than that. Usually this is well tolerated by healthy infants. It's a full-term infant, he will tolerate that much anemia. So you don't transfuse a baby 1 month old or 2 months old because you find hemoglobin of 9. That's actually a physiological anemia. It is well tolerated. Okay. However, the situation with premature infants can be slightly different because anemia can be worse. It can be up to 80, and the birth weight is usually preterm, so very low birth weight, and even can be less than 1 kilogram sometimes, and hemoglobin in these young children can be as low as 70 and maybe not tolerated by the infant. And if you have a preterm baby with very low hemoglobin, that's a proper indication if you want to transfuse. I brought this just to differentiate between the normal physiological anemia and the anemia of prematurity. Anemia of prematurity, again, because the EBO production is not yet developed. This baby liver, kidney functions and organ functions are not well developed, and at this stage the liver is the major site of EBO production before it changes to the kidney. Switch from liver to kidney source is dependent on gestational age and not influenced by birth. So EBO first will be produced by the liver, and once the child reaches to a proper gestational age, it will be shifted to the kidneys. And also in prematurity there could be more clearance of erythropoietin by the baby. He cannot hold the erythropoietin in his system. Other contributors like the survival of the red cells, there is a rapid growth of the child, he is developing quickly, so there is an increased volume and hemodilution. Neonates born before 28 weeks gestational age have not benefited from the bulk of iron transfer from the mother. This is a very nice and important thing to keep in mind. The children up to 3 to 4 or 5 months, their diet does not include usually iron. So from where this iron comes? It comes in the last trimester of pregnancy. A big chunk of the mother iron is transferred to the baby to maintain his development and his need for iron for his first few months of life until he starts eating food that contains iron. So if the baby is born premature, before he gets all this large volume of iron, then he will be definitely anemic. So this is a very important reason. Hemolysis due to hemolytic disease of fetus and newborn. This is when the mother develops antibodies that hemolyze and destroy the fetal red blood cells due to incompatibility between the mother and the father blood. It can be ABO related, or it can be also Rh antigens related. This is a whole topic by itself, we can discuss it some other time. But this is a very important part here, which is iatrogenic anemia or iatrogenic blood loss due to phlebotomy, which is a major cause of anemia in ICU, neonatal ICU patients. Remember the blood volume of a premature, we said how much? 150 ml. So how many tubes that will be? Like in few days you can drain him dry of blood. So mean level of sampling 0.8 to 3 ml per kg per day. That's when you are careful. So this blood collection may correspond to 30 up to 300% of infant's blood. You can take like 3 times the whole blood volume of the preterm and give him blood and take blood by phlebotomy. So this is very important concept for ICU doctors to keep in mind and try to avoid unnecessary blood sampling, because it will definitely cause anemia, iatrogenic anemia. This is all part of patient blood management. These special situations are more specific for pediatric transfusions. You have to be careful. Hypothermia, I discussed this in massive transfusion. If the patient is severely hypothermic, you need to raise his temperature up, because if he kept having low temperature, all his coagulation factors, his enzymes will not work. So regardless of what blood transfusion you will give, it will not cause any help. And hypothermia can cause increase in metabolic rate, it can cause hypoglycemia, it can cause acidosis, it can cause potential apneic events, or even hypotension and cardiac arrest. So hypothermia in pediatrics is very important, and remember, you are giving blood that is just taken out from the fridge, has been kept for temperature around 2 to 4 degrees, and that small body will not tolerate hypothermia for a long time. It can cause serious outcomes. So inline blood warmers are required for exchange transfusions because you are giving large volume, but avoid radiant heaters and phototherapy. These can cause hemolysis of the transfused red cells. Warmers are validated equipments that does not cause hemolysis in the red cells, and it's used for giving large volume, like an exchange transfusion. Potassium, there was a question about hyperkalemia today, and that is another situation where, especially for pediatrics, we need to be careful, because if you are transfusing large volume of blood, like more than 20 ml per kg, or if you are giving blood rapidly, or in infants younger than 4 months, if the storage medium is SAGM, for example, and we discussed this, the difference between SAGM and CBDA. We said that CBDA are better in reducing the risk of hyperkalemia, so the potassium leakage from the red cell unit is not much. If there is also irradiation, which you need to do sometimes, irradiation for the units, especially if the baby received intrauterine transfusion, then irradiation also is very well known to cause more disturbance to the red cell membrane and even more leakage of potassium. Units that are stored for more than 2 weeks are having more risk of having more potassium leakage on them. And if you are giving blood directly through a central line, potassium will go directly to your heart, to the baby heart, and that's where cardiac arrhythmias can happen. So these are important things to keep in mind in relation to potassium. So that's why we always prefer fresh blood for neonates when available. Of course, you don't stop transfusion just because you don't have fresh unit, but it is always better to give the fresh units available for your baby especially. And sometimes if you have to and you don't have other units, you may have to wash red cell units, but this is not practiced a lot. It has to have special equipments because we need to do washing in a closed system, and if you don't have a closed system washing equipments, then it will become an open system, you cannot use it. Some special hazards of transfusion in the neonatal period. Transfusion associated graft versus host disease. Anyone has any idea about this? So this is a very rare but very fatal, and the patient can die in few days. You don't know what happened. That's why after intrauterine and neonatal transfusions, irradiated blood products should be used. Irradiation kills the T cells in the units that is coming from the donor. These T cells, if it comes to a small baby with no immune system, it can cause graft versus host disease. It can affect his GI system. It can cause cytopenias and liver impairment. And usually if it happens, it is not treatable. The mortality rate is exceeding 95%. There's nothing you can do about it. This can also happen in adults. But it happens in different situations. It happens in adult patients who are severely immunocompromised because they are receiving strong chemotherapy, or they have some malignant disease that keeps them very immunocompromised. And if you have that situation, you ask for irradiated blood components. We do that in our center, and we can provide it to you. Usually these are very sick patients, very immunocompromised, and they are better treated in a tertiary care facility. And remember, if you irradiate the blood unit, it should not be used for longer than 14 days because of the changes happening in the red cells, lots of leakage of potassium and other particles. It should not be stored for more than 14 days. Transfusion overload is also a very important aspect you have to keep in mind when you are considering patient safety in pediatric situation. That's why I thought pediatrics, they need their own discussion. So transfusion overload is very easy. You just calculate this child blood today is, I don't know, 7 or 6. I need such and such volume to reach to the target hemoglobin, and you give everything at once. And with his weight, it's very easy to go to transfusion associated circulatory overload. His heart will start failing. He cannot pump all the fluid you are putting into him, in addition to the to the IV fluids that has been running for a while. So neonates are susceptible to volume overload because you are giving large volume of blood in relatively to their small body weight. So furosemide, this is not routinely given, but may be considered in some cases. For example, significant chronic lung disease or severe congenital heart disease. I mean, in some centers for children, they always consider Lasix mid-transfusion or so. But again, in pediatric, you have to be careful. Take into consideration the blood pressure, the hydration state of the patient himself. But is to avoid volume overload, which can result in a very ARDS picture in the lung, furosemide should be considered and kept in mind. If there is a risk that this patient having some heart disease or lung disease, then you consider furosemide mid-transfusion. This is another special hazard, especially for neonates. If the neonates having infections, they can develop something like T antigen activation. This can result in hemolysis of the red cells following infusion of plasma components. It can cause severe hemolysis. These T antigens activation happens after necrotizing enterocolitis, a famous disease in pediatrics, or after sepsis, most typically from gram-negative organisms such as Clostridium. So what happens? The red cells usually have polysaccharides antigens that gives the blood group and subgroups as well. But some bacteria have strong toxins. They destroy these surface antigens. And if the first layer of the antigens is destroyed, these subhidden antigens, which are called T antigens, will be shown to the surface. These antigens are usually human, like donor blood will be having naturally occurring antibody against T antigens. So you are giving the child who has necrotizing enterocolitis you are giving him a hemolysis. You are hemolyzing his blood because he has necrotizing enterocolitis. This should be picked up in the blood bank. That's why this sample should be referred before giving any plasma, because there will no blood be compatible with this patient. The mechanism is the enzymatic removal of sialic acid residues from the glycophorins, exposing the crypt antigens. They call them crypt antigens, are hidden. All adult sera contains naturally occurring anti-G IgM, which can cause severe hemolysis. Now let's talk about indications and thresholds for transfusion in children. There is actually lack of high quality evidence. There are no strong data and clinical trials to explain when we should use red blood cell in this age and that situation. But there are like two famous studies, the BIND and the LOA study, which were published in 2007 in New England Journal of Medicine, Transfusion Strategies for Patients in Pediatric Intensive Care Unit, that you can refer to. But today I will give you just some headlines. Remember, blood transfusion depends on the specific situation for the patient. There is a famous saying that not all people will fit in the same box. So these guidelines are just for you to have an understanding, but each individual patient, they have their own situations depending on their comorbidities and their other factors that you should assess. So it's not just the hemoglobin and hematocrit that you are treating. You are not treating a lab result. You are treating a human being. So consider other risk factors. Is there a risk factor for continuous bleeding? Is there a risk factor for the production is affected? Is there other medications this patient is taking that is causing anemia as well? And the most important thing is to identify the cause of anemia. Is this iron deficiency anemia? Is this anemia because of bleeding? Or there is another problem in the bone marrow of this child, for example. Expected course of anemia. If this is a transient anemia, then you can wait, support with some iron tablets. But if this is a chronic state of anemia, then you have to consider your blood transfusions. Special consideration in patients with ECMO and those who have heart disease, because they may need their hemoglobin level to be slightly in the higher side. They cannot tolerate anemia for a long time. This is taken from the BCSH UK guidelines. See, according to the age of the child, the state of the ICU admission of the child, if he's ventilated or he is just on oxygen, or if he is off oxygen. Let's start from the end. In the first 24 hours, this is, remember, this is a UK guideline, and their children usually have slightly higher hemoglobin levels than our. But they don't transfuse if the hemoglobin is above 10 or 100 gram per liter. You understand the difference between 10 and 100. 100 is 10. 100 gram per liter or 10 gram per deciliter. Remember I said the first 24 hours, the normal value of hemoglobin is usually 14 and above. So below 10 necessitates some transfusion. But then in the first week, that continues the same. Unless he is ventilated, then you have to, because ventilated is more sick, you have to transfuse in a higher threshold. And so on. This tells you that, and this is just general guidelines, but once he passed the first week, then you can go as low as 70 if he is asymptomatic and there are no other risk factors. This is just one example from the UK. You can find other guidelines from Australia, from Canada, from the US, and I think it's always better to have a local or a national guideline, because our normal reference range here in Oman could be slightly different from other countries. This is a very important part also to discuss regarding appropriate prescribing of blood for infants. infants or neonates are not expected to make antibodies. When we do the cross-match, we test for antibodies. So if we find an antibody in an infant sample, from where this antibody came? From the mother. Good. So that's why we need appropriate sample, especially from the cord blood, if you are suspecting hemorrhagic disease of fetus and newborn, because that will not affect your baby. Take blood from the cord immediately after birth if you are suspecting anemia or hemolysis or anything, so that you don't have to pick or to book the child and collect blood from his circulation. We do usually ABO and RHD grouping, the first, and that sometimes if it is indicated, an antibody screen if maternal sample is unavailable. Maternal samples are very important to do the same grouping antibody screen, because if antibody screen with the mother is positive, the same antibody here will find it in the neonate circulation. That's why cross-match is performed against maternal specimens for the first 4 months. And this is creating lots of confusion again. People are not happy because whenever they request blood in the lab, they ask them for a mother sample, and mother is not always available. But remember, this is only important if there is an antibody identified in the mother. So if the first sample, mother sample, was antibody screen negative, the other samples doesn't have to be cross-matched with the mother sample. So that will solve the problem. But if the mother has this antibody in the first sample, then the subsequent samples should be cross-matched with mother sample. Is that clear? Simple concept. Antibodies in baby circulation are not from his immune system, because he doesn't have any immune system. It comes from the mother. So if we want to cross-match any blood unit, if we cross-match with the baby, it will always be compatible. But these antibodies these units should be cross-matched with the mother sample, because that's where the antibodies will be coming from. But this should not delay the blood transfusion for the baby, because you are waiting for the mother sample and she is somewhere outside the hospital. If the first sample from the mother is negative, then the subsequent sampling could be done with just simple cross-match with the baby. Exchange transfusion is another important area to cover, and here it is indicated in severe anemia or severe hyperbilirubinemia. The aim is to prevent kernicterus, which is rare if in full term and bilirubin level is below 25, but if bilirubin is higher than that level, it can be a very high risk for kernicterus. Usually most centers use double volume exchange transfusion, and double volume means, remember, the volume of a term baby is 85 ml per kg, so then you calculate blood volume like 2 times 85 ml per kg of the baby. This is very important, and in pediatrics they have their own diagrams and their own indications when to go for exchange transfusion, or is it enough just to phototherapy, to have phototherapy for the baby. Radiation, as I said, this is very essential. If there has been previous intrauterine transfusion, and should be transfused within 24 hours of irradiation in the neonates, because the radiation causes lots of leakage of potassium and other unwanted effects. Usually the components for exchange should be plasma reduced, hematocrit within this range. Age of blood is usually fresh. As I said, we prefer fresh blood. CMV should be CMV negative, but leuko-reduced blood can be enough. There is a big debate now, is a leuko reduction equal to CMV negative? Most centers now start to take this approach as an acceptable approach. It should be hemoglobin S negative. Why for the baby? Because even a small amount of hemoglobin S level can cause problems in their circulation. And in Oman specifically, we have a high incidence of sickle cell carriers. So remember to do hemoglobin S for blood requested for children. And usually ABO compatible plasma or AB plasma is added just to maintain the coagulation factors. And whether to choose O negative blood or ABO specific, there is a big debate. Now many experts think that O negative should not be used if you know the blood group of the baby. You should use group specific. What is happening here for neonates?
Babies and mothers group.
Okay.
On that we choose. If it's not available, then we go for O negative.
Okay. So you first try to give groups specific. Good. For red blood cells, again, the dose should be calculated for babies as 10 to 15 ml per kg to increase the hemoglobin to 2 to 3 grams per deciliter. For FFB, the same dose used. And for platelets, it's like 5 to 10 ml per kg. This is because in the West they use pooled platelets, so they use slightly lower dosing regimens. For cryoprecipitate, it's 1 to 2 units per 10 kg of the weight of the baby. So this is a quick guide how you calculate the dose for blood transfusion in children. Thrombocytopenia, and as I said, this is very important to discuss today, and there could be some confusion sometimes. Remember, some situations and some diagnosis of thrombocytopenia, platelet transfusion is contraindicated. I can name for you ITB, immune thrombocytopenia, and TTP, thrombotic thrombocytopenic purpura, which can happen more in adults. If you transfuse a patient with thrombocytopenia and he has strong suspicion of TTP, thrombotic thrombocytopenic purpura, you may kill the patient because you are giving fuel to the fire. That's the expression they used in textbooks. The body is destroying all platelets in the system, and because of that destruction, lots of procoagulants are circulating, and the patient in a very high risk of thrombosis. And if you are giving more platelets, you are adding more risk to the patient. So not all thrombocytopenia cases should warrant platelet transfusion. This is very important. In addition to anemia, premature infants can develop thrombocytopenia also. 20 to 30% of ICU babies have thrombocytopenia. 25% of these babies have severe thrombocytopenia. The likely cause is combination of increased destruction and decreased production. Most feared complication of thrombocytopenia is intracranial hemorrhage or intraventricular hemorrhage in the brain. But this will not happen if the platelets are above. This is commonly can be seen in very low weight babies. If the weight is less than 1.5 kilogram, then there is risk of 20% of them to develop ICH. If the baby is born very, very low weight, that is half a kilo, less than 1 kilogram, there is a 45% risk of developing intracranial hemorrhage. And most of these intracranial hemorrhage occur in the first week. However, other factors other than thrombocytopenia play roles in intraventricular hemorrhage, coagulation factors and other things. This is the differential diagnosis of thrombocytopenia. It can be neonatal alloimmune, it can be ITB or SLE. Infections, all kinds of infections can cause thrombocytopenia. DIC, thrombosis, hypoxic injury like in prematurity and preeclampsia, diabetic mothers. These maternal complications can cause thrombocytopenia, or congenital conditions like trisomies, congenital leukemia, or abnormal megakaryocyte conditions. How you diagnose? If the thrombocytopenia happens in the first 3 days of life, these are your differential diagnosis. If it happens later, then you consider more of sepsis and other infections. And necrotizing enterocolitis is very important cause. Suggested thresholds of platelets. Again, it's just suggested. You can use your own local guideline based on different guidelines combination together. So platelet count less than 25 in neonates with no bleeding, including neonates with NATE, if no bleeding and no family history of ICH. Only if the platelet counts are below 30, and in some expert opinions below 20. However, if there is a bleeding, then you have to maintain platelet counts above 50. If there is CNS surgery or major neurosurgery or major bleeding, then you maintain platelets above 100. But if the child is not bleeding, platelets above 30, no need for blood transfusion. NATE is a very important topic, and it's one of the important differential diagnosis. If the baby is born like this, is born in the first day, and he has all these ecchymotic hemorrhage dots, you have to consider NATE unless proven otherwise. And this is usually due to antibodies produced from the mother that attacks the platelets in the child and destroy all his platelets. The risk is, of course, that the child can develop intracranial hemorrhage, and usually if this is very severe, you cannot do anything about it because the baby will be born already having intracranial hemorrhage. However, the management should be targeting the antibodies, and also if there is risk of bleeding, platelet transfusions, but it needs specific type of platelets. I will not go into details, for I think it's outside the scope of today's presentation. Frozen plasma should not be used for simple volume replacement. Never use plasma just to expand the volume of the patient. Meta-analysis of various trials have shown that fresh frozen plasma or frozen plasma shows no benefit as a means to prevent intraventricular hemorrhage or intracranial hemorrhage or respiratory distress or mortality, and they all do not improve neurodevelopmental outcomes. Poor evidence to guide when plasma is appropriate, but here are some indications. If the INR, if the BTA-BTT is more than 1.5 times the normal range, and there is a significant risk of bleeding, especially in invasive procedures, or there is risk of DIC or liver disease, then you can use frozen plasma. Other suggested indications: congenital factor deficiency, and you don't have a specific factor, like if this child is born with factor 5, even factor 8, and you don't have factor 8, you go to plasma. Cryo can be used if like factor 13 and 1 Willebrand deficiency. So the indications for plasma, especially in pediatrics, are very limited, and you have to think it twice before you ask for plasma transfusion. If the patient has chronic anemia, sickle cell disease, I will talk a little bit about sickle cell disease. These are all the complications of sickle cell disease. You have many sickle cell patients here?
Yes.
Okay.
Yeah.
So you are very familiar with sickle cell disease, and most of our samples refer to central blood bank for complex antibody workup, and complex blood transfusion workup is from sickle cell patients. And then second comes the maternal samples from the gynae. Then sickle cell is known to have all this cerebrovascular accidents, acute chest syndrome, splenic sequestrations, aplastic crisis, recurrent priapism, and preoperative anesthesia is planned. The target hemoglobin should be 10. Chronic transfusion programs for disorders of red cell production, thalassemia, or Diamond-Blackfan syndrome, unresponsive to therapy. These are other indications. So what I want to focus here today, which has more relation to blood transfusion, is the risk of alloimmunization. Patients with sickle cell disease have higher risk of developing antibodies. In general population, the risk is only like 0.5 to 1.5%, but with sickle cell patients, different studies report in different rates, and it can be as high as 76%. This can be reduced if we give RH matched blood, and that's what's happening now in Ibra. Yes, so we started for some time now in the Central Blood Bank to give all sickle cell patients RH phenotyped, RH uncle typed blood to avoid alloimmunization, because once antibodies develop, it's very difficult to find compatible blood. It costs lots of money and work and time to find compatible units. So the best thing is to avoid developing these antibodies. And they found from studies that most of these antibodies actually are one of those antigens, big C or little c, big E or little e, or kill antigens. So that's what we prophylactically give our sickle cell patients, match for RH and kill. And that have reduced the risk of alloimmunization significantly, up to less than 15%. For extended match, you can reduce it further to 7%. Why sickle cell have more risk of alloimmunization? Because there is a discrepancy between the antigen expression of donors and patients, and they receive lots of blood transfusions, so they have higher risk of alloimmunization. And the degree of antigen matching, as we said, if you give RH match versus extended match versus only blood group compatible, there is a difference in the risk. Age at first transfusion, it has been found that thalassemia patients has lower risk of alloimmunization because they start transfusion early in life. So their immune system is modulated to receiving foreign red cell antigens. But for sickle cell, they receive it slightly later in age, where the immune system is active. And sickle cell is a highly inflammatory state. And there is a genetic heterogeneity with sickle cell patients. Sickle cell patients, we found out that they have very specific gene mutations in their antigen, and that's exposed them to more risk of antibodies. There is many trials talking about silent cerebral infarcts. Now, we know that sickle cell cause strokes, but they found out even those patients who have no risk for stroke, they do poorly at school. So some researchers, they collected group of these patients, they did CT scan, it was normal, so they decided to do MRI, and they found out there are minor small infarcts, they call it silent infarcts, that doesn't cause any sensitive or motor disability, so it's not called stroke, but it can cause cognitive dysfunction, and sickle cell patients may do less than regular patients, people at school, and that's the reason. And even in this article, they recommended transfusing this group of patients. What we need to do, as I said, currently we are transfusing prophylactically matched for big C, little c, big E, little e, and kill. It's very useful to do patients phenotype. All sickle cell patients should be phenotyped for the first visit. Patients who have developed an antibody or multiple antibodies, then you give the RH matched, and in addition you either give extended phenotype match or you give antigen negative in addition to the RH matched. Transfusion can be simple or can be exchange transfusion. That's we'll try to be quick. Exchange transfusion in sickle cell is very effective but underutilized. You do exchange transfusion here? Yes. Manual or automatic? Manual. And prevents exchange transfusion prevents the removed sickle cells from participating in new vaso-occlusive crisis, and it reduces the hemolytic complications. It provides added oxygen carrying capacity, decreasing the blood viscosity. Remember, the aim in sickle cell patients is not to increase hemoglobin level. This is very wrong. When you think of treating a sickle cell patient, you want to improve his hemoglobin. Actually, you want to reduce the hemoglobin S, not to improve the hemoglobin. So if the patient comes with a hemoglobin of 9 and he is having acute chest syndrome, you don't want to transfuse him. You want to exchange transfusion. You want to take the hemoglobin S from his body and give him some normal hemoglobin to help him pass this acute crisis. What happens if you transfuse a sickle cell patient to hemoglobin level above 10? Yes, so there is a high risk of cerebrovascular accidents. And that's when transfusion is actually harmful, not useful for the patient. Hyperhemolysis is the last slide. It is a very difficult situation that sickle cell patients can develop. And has it ever happened to you that a sickle cell patient came with a hemoglobin of 6, you transfused him 1 unit, next day his hemoglobin is 4, you gave him another unit, his hemoglobin is 3.5, another unit, he reached up to 2. Alhamdulillah, it doesn't happen a lot, but this is what we call hyperhemolysis. A state of transfusion reaction where the immune system started destroying all red cells, the transfused ones and the patient's own red cell. And that's related to developing either a new antibody or not. The mechanisms are theoretical and it's called bystander hemolysis. I don't know, there somewhere. But the treatment is very difficult. The best thing is to try to avoid blood transfusion in this patient. And IVIG have been used, methylprednisolone, rituximab. They have tried all sorts of things, but it is really a difficult situation for the treating physician, and they need to consult tertiary care hospital for advice.
How do you know?
Yes. Okay, so let me discuss it in more details because you seem interested. This is a serious transfusion reaction characterized by the destruction both donor and host, donor and patient cells. Okay, it happens in sickle cell, but it has been also reported in other diagnoses like thalassemia or anemia of chronic disease. Hyperhemolysis is used, the term is used because the post-transfusion hemoglobin is often lower than the pre-transfusion hemoglobin. So the patient, sickle cell patient, comes with a hemoglobin of 6. You say that will transfuse him, but instead of improving his hemoglobin, he developed hemolysis and he further dropped his hemoglobin. Okay. The possible mechanism of hyperhemolysis is called bystander hemolysis, suppression of erythropoiesis, and red blood cell destruction due to contact lysis from macrophages. This is luckily a transient, but it can happen again. So if the patient developed hyperhemolysis today, you have to be careful next time when you transfuse him because he can develop another time hyperhemolysis. How do you know? Simply because the hemoglobin level keeps dropping after each transfusion you give him. You are making the situation worse. Is it clear? And as I said, additional transfusion should be avoided because this may exacerbate ongoing hemolysis and worsen the degree of anemia. The management is not yet clear. They have tried all sorts of treatments, but the efficacy is not very well developed. And that's it. Thank you very much. I will leave it to Dr. Altaf next.